If you're a man in your 30s or 40s and you've been feeling like something is slightly off, not sick, not broken, just not quite yourself, I want you to hear something. That feeling might not be stress. It might not be aging. It might not be just how it is now. It might be a number you probably never had measured, and a number that has been declining in men your age, not just with time, but generationally, for decades. 1 in 5 men under 40 has testosterone levels that meet the clinical definition of deficiency. 4 in 10 men over 45. Most of them have never been told, not because their doctors don't care, but because nobody asked the question. Today, I want to ask it, and I want to answer it honestly, including where I personally stand in this conversation, because this isn't just something I prescribe. It's something I take for myself. Welcome to Honestly. I'm Chris Lee, MD, plastic surgeon and aesthetic medicine physician in Boston. This is the show where I answer the questions honestly, without reservation, as I would to any of my close friends that preface the question with the phrase, honestly, tell me the truth. And I want to start today's episode a little differently than usual. About myself. I'm in my, let's say, mid to late 30s. I'm 3 years into practice. I work long hours. I train 3 to 5 days a week. I try to sleep enough. I eat reasonably well. By most objective standards, I'm doing what I'm supposed to be doing. And yet, if I'm completely honest, there are days where the energy isn't what it used to be, where the motivation to push into the gym isn't automatic and the way it used to be, where recovery is slower than it was when I was 28. And if I'm being honest, and if I'm being honestly a little vain, where my body isn't where I want it to be aesthetically. Now, I'm also a physician, and I know exactly how easy it is to attribute all of that to workload, to adult life, to this is just what your 30s feel like. That narrative is available. It's socially acceptable. And for a lot of men, it becomes a story they tell themselves for years, while something correctable is quietly sitting in a lab panel their doctor never. I've had my testosterone checked. I'll tell you what I found and what I've done about it. Not because my situation is typical, it may not be, but because I think there's something powerful about a physician saying, here's what I actually look at for myself. Here's how I actually think about this. And that's the honest version of this conversation. And that's what today is. So let's talk about testosterone. What's happening to it in men as a population? What low levels actually look like and feel like beyond the libido cliches, and what to actually test and what the numbers mean, what treatment involves and who it's right, and where the newer adjunct therapies fit in. All of it. Here's the thing that doesn't get enough attention. Testosterone levels in men aren't just declining individually with age, which they do, about 1 to 2% per year after 30. They are declining generationally. A man in his 30s today, on average, has measurably lower testosterone than a man in his 30s had in the 1980s. Not because he's older, but because something in the environment, the lifestyle, or both, has shifted at a population level. The data comes from large longitudinal studies in the US and Europe tracking testosterone levels across decades. The decline is real, it's consistent, and it's been observed even in men with normal BMI, which rules out obesity as the sole explanation. Environmental exposures, endocrine disrupting chemicals, microplastics, declining sleep quality, sedentary patterns, all of these are on the list of suspected contributors. None of them are fully established, but the trend is not in question. It is real. The standard clinical cutoff for testosterone deficiency is 300 nanograms per deciliter. If your total testosterone comes back below 300 on 2 separate morning draws, you meet the clinical diagnostic threshold for hypogonadism. That's the scientific and clinical definition. But here's where I want to push back on how this is often applied in practice. 300 was developed as a reference range, largely derived from older male populations. For 25-year-old male, normal is not 300. The average healthy male in his 20s runs 600 to 1200. 300 in a 35-year-old male may be technically not deficient by the clinical definition, while still representing a level that is meaningfully suboptimal for the person's age, symptoms, and quality of life. The cutoff is a diagnostic floor and not a target. I want men to understand this distinction because it's the thing primary care doctors most often miss. And honestly, I don't blame them because med school did not train us to treat normal. Your labs can come back normal in range and still represent a real problem for your specific situation. The number has to be interpreted alongside symptoms. And normal should not be the same for a man in his 40s and a man in his 70s. So why do we only have one scale? There's a cultural weirdness around men talking about hormones. Testosterone supplementation still carries in some circles an association with performance enhancing drug use, with bodybuilders, with something slightly illicit. And that association, however unfair, keeps a lot of men from having the conversation that is fundamentally about correcting a documented physiological deficiency. We don't treat diabetes patients who are insulin deficient and tell them to push through. We don't tell thyroid patients to accept their fatigue as a character building exercise. But men with documented low testosterone are frequently told, explicitly or implicitly, to just manage their lifestyle better. Work harder at the gym. Lift more. Sometimes lifestyle is the answer. Often it's not the whole answer and it isn't enough. When most men hear low testosterone, the first thing they think is libido. And yes, decreased sex drive is a symptom, but it is one symptom on a list that is much longer and, for most men, more disruptive. Libido being somewhat lower is something many men either don't notice or attribute elsewhere. It's the other symptoms that actually erode quality of life, and those symptoms are the ones that often fly completely under the radar. Let me walk through what testosterone deficiency actually looks like across domains, starting with energy and vitality. The kind of fatigue I'm describing isn't "I didn't sleep enough last night" fatigue. It's baseline depletion, a ceiling on your energy that feels fixed, where even after adequate rest, you don't feel fully restored. Men describe it as losing the drive that used to be automatic, getting through the day instead of attacking it. Body composition is another one. Testosterone is an anabolic hormone. It promotes muscle protein synthesis and lean mass maintenance. When it drops, the hormonal environment that supports muscles simply isn't there. Men start losing muscle mass even when they're training consistently. Simultaneously, visceral fat, the fat around the abdomen and visceral organs, the metabolically dangerous kind, increases. That combination creates a body composition that resists conventional interventional. You're in the gym, you're watching what you eat, and the results don't match the effort. That's a physiological problem, not a willpower problem. Mood and cognition are where I think the most harm is done by the silence around this topic. Low testosterone is consistently associated with increased rates of depression, irritability, anxiety, and reduced motivation. It's associated with decreased ability to focus, what men often describe as mental fog or dullness that wasn't there before. These symptoms get treated with antidepressants, with therapy, with lifestyle adjustments, sometimes appropriately, sometimes as a patch on something that has an underlying hormonal cause that nobody's measured. There's also sleep quality, bone density over time, red blood cell production, and cardiovascular health, all of which testosterone supports at a physiological level, and all of which are affected by deficiency over time. This is a systemic hormone. Its decline has systemic consequences. Honestly, scale on how well the medical system, primary care specifically, serves men experiencing testosterone deficiency, I'm going to give it a 2 out of 10. The testing is available, the treatment is available, the evidence base is substantial. The gap is almost entirely in awareness. Patients not knowing to ask, physicians not proactively measuring, and discomfort with prescribing. And I know this because I was one of those doctors once. Male hormones and hormone optimization were never really talked about in medical school. A 45-year-old woman presenting with fatigue, mood changes, and body composition shifts in a primary care office would almost certainly have her hormone levels checked. A 45-year-old man with the same presentation, statistically, often would not. Testosterone is diurnal, meaning it peaks in the early morning and declines throughout the day. This matters for testing. Labs really should be drawn in the morning, ideally before 10 a.m. An afternoon testosterone level is essentially useless for diagnostic purposes because it will naturally lower and may be falsely low, suggesting deficiency in someone who is otherwise fine, or mask a real issue by catching a partial peak. Two separate draws on different days if the first comes back abnormal. That's the clinical standard before making any treatment decision. This is the gold standard for testing. It doesn't always happen in actual practice, but it's how to get the best assessment of your baseline. Here's what a meaningful hormone evaluation for a man should include. Total testosterone is a starting point, but it's not the whole story. You also need free testosterone, which measures the biologically active fraction that isn't bound to proteins. You can have total testosterone that looks acceptable, while free testosterone is functionally low because of elevated SHBG, which is sex hormone binding globulin. This binds testosterone and makes it unavailable. Both numbers matter. Beyond those two, LH and FSH, so luteinizing hormone and follicle stimulating hormone, tell you where the problem originates. A high LH with low testosterone means the brain is calling for more testosterone, but the testes aren't responding. That's primary hypogonadism. A low LH with low testosterone means the signal from the brain is inadequate. Secondary hypogonadism. And the approach to treatments differs. Knowing which you're dealing with is clinically important. Estradiol, your estrogen level, matters too, especially if you're on or considering TRT. Testosterone aromatizes, or aka is converted to estrogen, and elevated estradiol on TRT produces its own set of symptoms. PSA is important if you're over 40, which is prostate specific antigen, because that's a necessary baseline before and during testosterone therapy. CBC is for hematocrit or your blood levels. Testosterone can increase red blood cells production, which is usually beneficial in small amounts, but requires monitoring because a really high elevated hematocrit increases risk for clots. And a comprehensive metabolic panel is also important for overall health context, including A1C, liver functions, and kidney functions. That's your panel if you're just looking at testosterone. Total T, free T, SHBG, LH, FSH, estradiol, PSA, if indicated, CBC, and a CMP. If you walk into any physician's office and ask for that panel, they can order it. Many won't suggest it unprompted, but you should ask anyway. The range on a standard lab report for total testosterone is typically 300 to 1200 nanograms per deciliter. That is an enormous range. A man with a level of 350 is normal by the lab's flag, but for a 35-year-old, that's the bottom 15% of the population. Context matters enormously. I tell patients the number alone doesn't make the decision. The number combined with your symptoms, your age, your goal, your baseline, that's the conversation that needs to happen. The optimal range for most symptomatic men who decide to treat, per the most recent clinical guidelines from the American Urologic Association, is around 450 to 600 nanograms per deciliter. That's the mid-normal range. I think getting my patients up to 500 to 1,000 on the upper end of normal also has additive benefits. It's not super physiologic, not trying to turn a 40-year-old into a 20-year-old, just restoring what should have been there. That distinction matters, ethically and clinically. If you and your physician decide that TRT is appropriate, the next question is how to administer it. There are four main options, and each has real trade-offs. Injections, either intramuscular or subcutaneous, are the most common, and in my opinion, the most clinically controllable. Weekly subcutaneous injections of testosterone cypionate or enanthate provide consistent levels without the peak or troughs you get from older every 2-week intramuscular protocols. You can do them at home. They're inexpensive. But the downside is that it requires self-injection and sometimes into your muscle, which some men are resistant to initially. There are topical gels, which are the most widely prescribed form in the US because they're easy. Apply daily to the shoulder or upper arms, but the downside is absorption variability, so not everyone's getting the same dose, and the risk in inadvertent transfer to partners or children through skin contact, which is a real clinical concern, especially in households with women of childbearing age or young children. Pellet implants are great. Small pellets inserted subcutaneously every 3 to 6 months provide extremely consistent levels with the least amount of peak and trough without daily or weekly administration. The downside is that once they're in, you can't adjust the dose. Other than adding. If there's a problem, you wait it out. So for men who dial in their ideal protocol, pellets are excellent. For men who are still figuring out their dose, it's a little less forgiving. Rule of thumb is to start small and add if necessary. Oral testosterone is available. It's FDA approved, but absorption and metabolism is more variable between patients, and it requires twice daily dosing. It's a reasonable option for men who are just absolutely injection averse or pellet averse. Here's the single most important thing I want men in their 30s who are considering TRT to understand. And it is underemphasized everywhere I look where TRT is given. Exogenous testosterone, testosterone from outside the body, suppresses something called your HPT axis. That's your hypothalamic pituitary testicular axis. When you give a man testosterone from the outside, his body reads it as we have enough, shut down the production. So the testes stop making testosterone because the brain stops telling them to. And critically, they stop making sperm. TRT, in the absence of other interventions, is a contraceptive. This doesn't mean men who want children can't optimize their testosterone. It means the approach needs to account for fertility. There are two main options. The first is to use enclomiphene rather than exogenous testosterone. Enclomiphene is a selective estrogen receptor modulator that stimulates the pituitary in your brain to produce more LH and FSH, which then drives the testicles to produce more testosterone and sperm naturally. It raises testosterone without shutting down the axis that we talked about. It's the right first-line choice for men who want to preserve or optimize fertility because it will make you more fertile. 2, if you're on TRT and want to preserve fertility, HCG, human chorionic gonadotropin, can be used alongside testosterone to maintain testicular function and sperm production. Both approaches exist, both work, but you have to have that conversation before you start and not after. TRT isn't something you start and forget. The monitoring protocol matters. At 3 months after starting, recheck total testosterone, free testosterone, hematocrit, estradiol, and PSA if you're over 40. Then every 6 to 12 months thereafter, once stable. You're watching for levels in the therapeutic range, for hematocrit trending too high. About 45% is the threshold for pausing or adjusting your dose. And for estradiol climbing into a symptomatic range, which manifests in fluid retention, mood instability, or gynecomastia, which, for those out there who don't know what that is, it's man boobs. A physician who starts you on TRT and doesn't have a monitoring schedule is not doing it right. This is a medication that requires ongoing partnership between you and whoever's managing it. Now, I want to spend a few minutes on adjunct therapies because the hormone conversation doesn't exist in isolation. For many men, testosterone is the place to start, but it's not the whole picture. There are things like growth hormone, which also decline with age, and its declining produces a distinct set of consequences. Reduced muscle recovery, increased fat accumulation around the belly, diminished sleep quality, slower healing. For men whose testosterone is optimized but who are still experiencing these issues, the growth hormone axis is worth evaluating. Sermorelin is a growth hormone releasing hormone analog. That stimulates the pituitary to produce more growth hormone naturally rather than administering synthetic growth hormone directly. The evidence supports improvements in body composition, sleep quality, and recovery over 3 to 6 month course. Most patients notice improved sleep within 2 to 4 weeks. Body composition changes follow over 3 to 6 months. It's administered as a nightly subcutaneous injection, typically 5 nights a week, with 2 days off, and done in cycles of anywhere from 3 to 5 months. Now that we're wading into peptides, I do want to be honest about the regulatory landscape here because it's shifted significantly and it's hard to understand. The FDA did crack down hard on compounded peptides in 2024. BPC 157 and TB 500, two healing peptides with a loyal following in the performance and recovery community, are now in regulatory limbo. Their evidence base is primarily in animal studies, and the FDA has issued explicit warnings. Sermorelin remains prescribable. Growth hormone secretagogues, or like sermorelin as a category, are kind of in a gray zone. If someone is offering you a peptide protocol, you need to ask which compounds are actually FDA approved or legally prescribable from a licensed compounding pharmacy versus what's available as a research chemical, which is a category that exists in regulatory gray territory. The reality is even non-approved peptides may have significant health and aesthetic advantages. However, they also don't have long-term safety studies. So even at baseline, you take these at your own risk. On top of that, if you're not sure exactly where they're being made, you could be putting yourself at risk for heavy metal poisoning or contamination. If you're going to take something that is not FDA approved, you need to understand these risks and at least know where your medication is coming. Here's the thing I tell every patient before we talk about anything, pharmaceutical or injectable. Testosterone therapy will not fix 5 hours of sleep. Sermorelin will not fix chronic stress. Peptides will not replace resistance training and adequate protein intake. These are tools that amplify a system that is functioning. They do not substitute for the system. The men who get the best results from hormone optimization are the men who have the lifestyle foundation in place and are hitting a ceiling that they can't break through. If that foundation isn't there, you need to build it first. The ceiling will be higher than you think. So let's get to some questions. All right. I'm 32 and I've been feeling exhausted and unmotivated for about a year. My primary care doctor ran labs and said everything looks normal. Should I push back? The answer is yes. And here's specifically how. Ask your doctor what your actual testosterone number was, not just whether it's flagged. If it came back above 300, it will not be flagged as abnormal, even if it's 310 and you're 32. Ask for the free testosterone value and whether sex hormone binding globulin SHBG was measured. If those weren't tested, ask for them now. And ask whether the draw was done in the morning or in the afternoon. If it was in the afternoon, it needs to be repeated. If your doctor's resistant to this, and some will be, because this isn't a routine part of the primary care workflow for your age, you have two options. Find a physician who has an interest in men's health and hormone optimization, or work with a telehealth-based men's health practice that specializes in this. The field has moved. The access is much improved. You don't have to accept normal as a complete answer when you don't feel normal. Question 2. I've heard TRT shrinks your testicles and makes you infertile. Is that true? I'm 38 and might want kids in the next few years. So this is partially true and critically important to understand before starting anything. Exogenous testosterone does suppress the HPT axis like we discussed, the signaling pathway that drives testicular function. When that axis is suppressed, testicular size can decrease and sperm production drop significantly. So yes, if you start TRT in the conventional sense, exogenous TRT and testosterone, and you want biological children in the next few years, you need to have a different conversation with your doctor. The good news is that it's entirely navigable. If your testosterone is clinically low and you want to treat it while preserving fertility, enclomiphene is your first choice and first conversation. It raises testosterone through your own axis, stimulating your pituitary and testes to do more of what they're supposed to do without the suppressive effects of exogenous testosterone. Your sperm count can actually improve on enclomiphene because you're improving your LH and FSH signaling, which then talks to drive sperm production. If you ultimately choose TRT exogenously, so given through injection or however, HCG can be added to your protocol to maintain testicular function. But honestly, for a 38-year-old who wants kids in the next few years and has low to suboptimal testosterone, enclomiphene is where I'd start the conversation. The fertility question is not a reason to do nothing, but it is a reason to make sure you have the right tool. Good question. Question 3. My doctor says my testosterone is low at 340, but he doesn't think I need treatment. I feel terrible. What do I do? So I hear this constantly. 340 is not deficient by the diagnostic threshold or standards of scientific method, but it is at the 18th percentile for men in their 30s or 40s. It is well below what would be considered optimal for the midpoint of the normal range. And if you feel terrible, fatigue, mood, body composition, motivation, that context matters enormously and you should do something about it. What I'd say to you is get the full panel if you haven't, for all the things that we talked about. If your free testosterone is low despite total of 340, which it can be, especially if your binding globulin is elevated, then the clinical case for treatment strengthens. If the free testosterone is adequate and your symptoms persist, there may be other contributing factors worth evaluating. Thyroid, cortisol, vitamin D, iron, all of which we try and test for when we first test you here in our office. And if the full picture supports treatment and your primary care physician is still not on board, you got to seek a second opinion. Not because your doctor is wrong to be thoughtful about this. They're right to be thoughtful and cautious. But I feel terrible and my lab suggests suboptimal testosterone is a legitimate clinical problem that deserves a legitimate clinical response. You are your own advocate here. Be persistent because not all doctors, as I said, are comfortable with testosterone therapy or low testosterone diagnosis. So keep going. If they don't help you, find someone who will. I want to close with where I personally land on all of this because I've been talking about this in the third person. What men should do, what the data says, what the clinical guidelines recommend. And I think honesty requires me to put myself in the picture. I've had my testosterone checked more than once. My levels have been the low normal range, but as I've described today, normal range doesn't tell the whole story. I look at my free testosterone, my sex hormone binding globulin, my trend over time. I think about this the same way I think about any other biomarker. Where am I relative to my optimal for my age, my activity level, my goals? Not just where am I relative to, a diagnostic floor of deficiency. I have been on TRT. I love the improvements I was feeling in my libido, my sleep, body composition. Without changing anything else in my diet or exercise routine, I was seeing gains at the gym I had never before been able to reach and breaking through long held plateaus that I thought were insurmountable. I'm currently on a break from TRT because of the body acne that I'm getting under control, but fully intend to restart once I do. What I'm committed to is not accepting a slow decline as inevitable without asking whether it's correctable. That's the whole point of today. Not everyone should be on testosterone. Not TRT is the answer, but know your numbers. Understand what they mean. Don't let cultural taboos around this conversation prevent you from having it. And find a physician who takes it seriously, who sees you as someone optimizing your health, not someone just looking for a shortcut. So that's it for episode 4. If you've got a question, send it in the comments or the DMs. Follow us at Honestly Pod. If you know a man in your life who needs to hear this, send him the episode. Links are in the show notes. DMs are open. I'm Chris Lee, MD. This is Honestly. See you out there.